This is Blood and Cancer, the official podcast of MDedge Hematology Oncology. I am the voice of MDedge Podcasts, Nick Andrews. And welcome to episode 77 of Blood and Cancer. I am Nick Andrews. We've got a special episode for you this week. Dr. David Henry, who is normally the host of this show, especially the interview segment, is vacationing as we record this somewhere near a large body of water. So on that note, we hope you and yours have a happy and safe holiday, or had a happy and safe holiday if you're listening to this on your drive back to the real world. And for all of our international listeners, we hope you have a happy and safe weekend while we celebrate American Independence Day. Coming up in this edition of Blood and Cancer, we used to have Clinical Correlation that bookended our show, which is the human side of hematology and oncology care. Those segments were written, recorded, and produced by Dr. Ilana Yurkiewicz, who is a hematology oncology fellow at Stanford out in California. Dr. Yurkiewicz has stepped away from Blood and Cancer, and we really thank her for her time. We all miss working with her tremendously, and I suspect very strongly we have not heard the last from Dr. Ilana Yurkiewicz. She will be back and better than ever at some point, or maybe she'll just drop by for the occasional conversation. We would really, obviously, enjoy having her back. But for this special edition, this holiday edition of Blood and Cancer, we thought let's look back on the contributions of Dr. Yurkiewicz to the podcast and to MDedge Hematology Oncology. So we have 4 episodes of Clinical Correlation, just Clinical Correlation, and we have probably the most harrowing conversation that she had on this show, which was difficult conversations that residents and fellows and trainees have in hematology oncology care. She did a 3-part conversation with some of her co-fellows, and the first question that they posed to themselves was what to say when a patient asks, how long do I have left? Then after that, we're going to go to Clinical Correlation. We're going to discuss some family dynamics and the optimism bias, and of course, we will address something that is probably higher than ever right now in the COVID-19 pandemic, which is patient anxiety. So enjoy this special edition of Clinical Correlation and the best of Dr. Ilana Yurkiewicz. Don't forget, you can email the show at podcast@mdedge.com. You can follow us on Twitter at MDedgeHemonc. We'll be back with new content on episode 78, and we hope you and yours once again have a happy and safe American Independence Day.
I'm Dr. Ilana Yurkiewicz, and I'm delighted to host this week's episode on preparing for fellowship, with the particular topic that we're going to focus on today being difficult conversations that come up frequently during fellowship. I'm delighted to be joined here today with 2 residents from the University of Pennsylvania, Dr. Emily Breyer and Dr. Ronick Mistry. Welcome to the show.
Thank you.
So, like I said, our goal today is to address some common hard situations that come up for new fellows. So the way we're going to run this interview is I'm going to run a few cases by you guys, and I'm hoping we can have an open discussion about what makes these situations challenging and what are some ways to handle these situations. And all of these cases that I'm going to bring up are actually based on real experiences that I've had during my fellowship. So the first case I want to talk about, the theme is, how long do I have to live? And here's the case. So a 65-year-old woman with no significant past medical history is referred to your clinic for a new diagnosis of lung cancer. She presented with a cough, had a chest x-ray and a CT showing a lung mass. She underwent a bronchoscopy with biopsy showing non-small cell lung cancer, and a PET scan unfortunately showed that she had diffuse metastases in her lymph nodes and liver. She has no targetable mutations. You discuss first-line options for immunotherapy and chemotherapy. You do tell her that her cancer is metastatic, so we are aiming for shrinkage or stabilization of disease. All of a sudden, she breaks down and shows you a picture on her phone of her 1-year-old grandchild. She asks you, "Doc, how long do I have to live?" So before we kind of get into the meat of how to deal with this conversation, I wanted to ask you guys, have you ever experienced anything like this during your residency?
I definitely have. And oftentimes it is, it's when you're meeting these patients for the first time coming to the hospital, they're seeing a new resident, a new face, and they're just scared. And I think, Emily, maybe your experience is a little bit different, but in my experience, it's been that they're looking for hope because they have had this difficult conversation with their oncologist already, and they're hopeful that having someone else in the picture now, someone fresh, someone new, might be able to tell them something that they hadn't heard before. So it's almost like a unique situation to what you're describing, I think, but nonetheless something that I know I've experienced for sure.
And I definitely have had similar experiences to what you described, Ronak. Even in patients who are hospitalized when their cancer is first diagnosed, and they ask, the resident or, something that we may not necessarily know without speaking with the attending first, but they're difficult situations for sure.
Yeah, and I know it's really hard, and seeing this a lot of times, sometimes it can make it easier, but often it's still difficult every single time. And so I think what you guys are saying, specifically, Ronak, what you said about the patient looking for hope, is really astute. So I think the first thing I wanted to just say about this case is when this patient breaks down and, shows you a picture of her grandchild and she asks you this question, she's asking an emotional question. And I think, as physicians, our instinct can be to just start throwing information, at patients and start throwing content at people. But it's really important to recognize when the question is stemming from emotions rather than actually seeking information. And we can get to the information later, but it's really important to respond to the person's emotions first and create safety in the conversation. Because if there's no feeling of safety in the conversation, no amount of content you say will sink in. So
I completely agree.
What are some ways you think you can make this patient feel safe and feel validated?
I think for me, what has worked in the past is trying to dig a little bit deeper and see what's actually on the patient's mind. In this case, the patient is showing you this photo of her grandchild, and there's something deeper there. I think that simply, again, in my experience, discussing with the patient what their apprehensions are, what their fears are, what their hopes are, just having that honest discussion can sometimes really make a big difference in how the patient's demeanor is, and this idea of being so scared and wanting to know how long they have to live. I don't want to say it completely goes away, but they feel more okay with the prognosis of the disease because they simply have developed a relationship with the physician. And I think that that's huge.
Yeah. Emily, any thoughts?
Yeah, I feel similarly, and I agree that it's such a difficult situation, but it provides you an opportunity to clarify kind of what the patient's worried about, and as Ronak said, what their hopes are, but also to align your goals as a provider with their goals for treatment, but also their goals for family and for life, and to kind of reiterate that you most likely share the exact same goals as the patient to help them keep them as well as they can be for as long as they can be, so that they can maximize this time with family. And I think all of that goes to, helps to add to the trust to the level of the patient to the physician, and physician to the patient, and can have a more comfortable relationship to talk about more kind of data and treatment options kind of down the road after that initial trust is established.
Absolutely. I completely agree. It's clear both of you have already experienced situations like this and have some expertise in dealing with them. And it's really great to hear you speak about this. So I completely agree about the trust aspect. If the patient doesn't feel like they're in a safe situation where they can trust you as the provider, like I said earlier, no amount of content is going to stick, and no amounts of content is actually what they're even looking for. And I think what you're both describing is a patient-centered approach to care, and a shared decision-making model where you're trying to tease out what's most important to the patient and what their values and wishes are, and also what their concerns are. So when someone's asking, how long do I have to live? Often I will just say something more specific, like what concerns you? What concerns you specifically? And that can start teasing out what this person's values are, so that you can then make the best possible decisions together about how to get them to reach those values. So then going a little bit ahead, so we talked about, this is an emotional question. You both, perfectly astutely described how you have to establish trust first and validate the person's emotion. Now, assuming you've done that, so the person feels safe, she's no longer crying, and now she kind of pushes again, and we're getting into the content portion of the conversation. So she asks, how long do I have to live? And, this is a really, really difficult question. And it's also one of the most common questions that we get in hematology and oncology. And in terms of actually answering that question with content, I'm wondering if you guys have an approach to that.
I think you touched on it earlier when you mentioned that the patient was metastatic and the goal for the treatment would not be curative. It would be to stabilize the disease and, shrink it and prevent the progression. So I think that I would focus on that and kind of talk about that timeline and explain that it's, kind of impossible to predict and to give an exact time.
I completely agree. I think that the severity of the disease, even without reaching for, these calculators and prediction models that are available, in itself would suggest that this is, we're talking possibly on the timeline of months here. And, I think it's, in this case, as long as, like Emily said, we acknowledge that we don't have a crystal ball and we don't know exactly when that time is going to come. I think it's best, based on what we know, to give them a timeline of months. And, in the best case scenario, it extends to, in the order of years, but we have prepared the patient with the mindset that, the next few months are going to be difficult.
Yeah. So it sounds like, Ronak, you would lean towards giving more specific data, for example, months. Would you ever give a number?
I think that at this point in my career, I don't think that I've seen enough to feel comfortable giving a number. I think that by giving the order of months, again, I think it mentally prepares the patient for what's to come. And as we've both been describing, if really what we're hoping to achieve here is ensuring that our goals and the patient's goals are kind of moving in parallel, then by providing this timeline, I think it helps us also to continue the conversation as to what is most important and how are we going to proceed in the near future in terms of treatment, or whether that be focusing more on comfort, finding more time for her to hang out with her grandchild. These are all important things that I would want to uncover. And I feel like by giving somewhat of a more clear timeline, we're able to kind of address all of these things in a more timely fashion.
Right. I think the issue that we're hitting on is how specific is the right amount of specific. So, I think, as Emily said earlier, it is really important to say, is this metastatic or not? Is this curable or incurable? I mean, that's really important information to know. And it's surprising, actually, how easy it is to overlook that in the first visit, that the cancer is incurable. And there are ways to say that without taking away hope, but it is important information for someone to know that what the goals of the treatment are. The goals are not to make the cancer go away completely, but to shrink or stabilize the disease for as long as possible. I think another point that you hit on really well is acknowledging that, doctors are historically bad at prognosticating. And I've said that openly to patients. There are studies that have shown this, that We use phrases like we don't have a crystal ball, but all of that kind of hits on the fact that if you survey a bunch of doctors about the same situation, they'll give a lot of different predictions about how long someone has. And, a lot of people are wrong, and acknowledging that and being humble about it as you go further along in your careers is incredibly important. And then I think the third thing that you hit on really well was about giving a range, but not honing in on one particular number. So I think you're thinking about this exactly right. If you give one particular number, I think, someone will hold on to that. And of course, even a number, if you give someone a median, that's just the median. I mean, what does that really mean? There's a huge range of how someone will do. So one good tip that I've heard from palliative care physicians and I've used before is giving a best case, worst case, and most likely scenario. If you get the sense from someone that they're really pushing for more specifics in content. Have you ever done that before with patients?
I have not personally been involved in a situation when that was used. I have commonly seen the palliative care folks give a range, as in, days to weeks versus weeks to months or months to years. So it's not as exact as you're saying, but I think sometimes that can also be a useful frame of reference.
And I think a lot of it is trying to get a sense of what kind of patient you're dealing with. And there are some people who really do want more granular information, and there are others who you'll get the sense, as you have already, that are okay with more generalizations, as long as you give some information that's just not so obscure that, so vague that they don't even know, whether it's curable or not. It is normal and it is okay to feel anxiety about a medical diagnosis. But there are also situations where that can actually get in the way of what's in someone's best interest. I recently met a patient who had a particular bone marrow syndrome that put him at a small but significant risk of developing leukemia later. His bone marrow wasn't causing him any problems right now. The anxiety about the possibility of developing leukemia was. I learned he quit his job so that he could better focus on what he called, quote, facing reality. He spent a lot of time on the internet looking up cases of other patients in similar situations. He was unable to focus on his day-to-day life. That's how overbearing his anxiety had become. He thought this was a good thing. It prepared him, after all, so that he would feel more ready if and when that day came. It was tough to try to get under this reasoning and to help him see that he could enjoy his everyday life now and that worrying excessively wasn't going to change what would happen in the future. Some people are amazingly well-equipped to deal with uncertainty. They live their day-to-day lives, and they prepare for the worst without letting it really affect them. This is impressive and really hard to do. I admire it. On the other end of the spectrum are individuals like my patient who can become so afraid of the worst-case scenario they're unable to enjoy the time they have now. I don't judge what he was going through. It's really tough to carry the idea in your head that you are at higher risk than other people of developing a serious illness. At the same time, I didn't want to let his anxiety affect my decision-making. There was a real risk here. When patients like him become that anxious, I can feel it starting to make me more cavalier about the facts. Any abnormal number in his labs, for instance, could provoke me to rush to reassurance, because talking about doing additional testing would be too terrifying for the patient to hear. Why? What are you afraid of? What should I be afraid of? Doing your job well, doing due diligence without adding to the anxiety of an already very anxious person is a tough thing to do. You are responsible for a person's health, yes, both physical and mental, but ultimately you are responsible for making the right calls, even if that may add to a person's anxiety. It was good to actively remind myself of this, as one of his labs did come back abnormal. I did exactly what I would do for any other person, and not hold back because of the reaction I feared. There are many well-known cognitive biases in medicine. One we see in oncology is the optimism bias, when you believe you're less likely to experience a negative outcome. It applies to patient thinking, but it also applies to physician thinking. Especially if you like your patients and have a personal connection with them, you're more optimistic about their outcomes. Recently, I've been reflecting on a conversation I had a few months ago with a new patient in clinic. He had presented to another hospital with an infection, and a CT scan showed he had extensive cancer throughout his abdomen, pelvis, and lungs. Biopsies confirmed it was all an aggressive metastatic sarcoma. He left the outside hospital even before his infection resolved in order to make his new patient appointment with us at Stanford. When I saw him in clinic, he was clearly not doing well. Besides the cancer, he was still septic and needed to go back into the hospital. But he and his wife wanted answers about his cancer, this horrible burden that had been suddenly and unexpectedly thrust upon them. I wanted to be honest about how serious things looked. I did tell him it was metastatic, it was incurable, and that we had treatments to slow down or halt its growth. But he kept pushing. It's treatable, right? We have something, right? I told them yes, to their obvious relief. I then told him he would need to go back into the hospital to deal with the infection. How long, they asked. Until it's resolved, probably a few days to a week, I said. I followed along his hospital stay. At the 3-week mark, I get a notice in my inbox from the inpatient attending. I am sorry that your patient did not survive. A palliative care doctor once gave us good advice about when to address end of life. They said if you wouldn't be surprised if you heard that your patient died within a year, now is the time. When I met this man in clinic, I would not have all been surprised if he passed away in the year. But it was our first visit, he was overwhelmed, he was reaching for optimism, and I gave it to him. I've been thinking about that conversation since I heard that he passed, and I wonder if I should have been more honest about my fears. At the same time, I think, why? They had plenty of conversations in the hospital as things evolved. Why should I have taken away hope, given all the uncertainty at the first visit? Optimism in cancer is a complex subject, and I don't want to simplify it in a few minutes. I will say, though, that I too am susceptible to the optimism bias. When I counseled him that first visit, I thought of the most optimistic version of his future, and I shared it. I don't think it's necessarily wrong or dishonest to be optimistic and hopeful. But I do think we should be actively cognizant of it, so we don't lull ourselves into false hope just because we like our patients. There's an old adage that cancer can either bring families together or tear them apart. Katie was in her 40s when she was diagnosed with acute myeloid leukemia. The chemotherapy made her lose her hair, and the transplant caused graft versus host disease with severe gut malfunction and skin problems. She had been living at home with her husband and a 10-year-old daughter. Initially, when she was in the hospital, her husband was at bedside all the time, asking appropriate questions about her diagnosis and treatment plans. But as time passed, he showed up less and less. Eventually, weeks went by when I didn't see him at all. The nurses picked up that she seemed depressed, and they would ask me, maybe have social work or psychiatry come talk to her. Depression with cancer treatment is not uncommon and completely understandable. There are immense changes to your day-to-day life and the big picture uncertainty. Then there are the changes to your family dynamics and the stressor that can bring out the true colors of someone you thought was on your side. At first, Katie told me, he would tiptoe around her, acting like he was going to catch something being near her. It made her feel unsupported and unloved. Eventually, he stopped coming at all. "This was not what I signed up for," were his last words to her. There's an old adage that cancer can either bring families together or tear them apart. There's also plenty of data showing that patients who have good social support do better medically than those who do not. When I see cases like Katie's, I wish there was something we as doctors can prescribe for someone who loses their social support midway through the toughest journey of their lives. We can't, of course, but we can lend a listening ear, and even though it's not the same, affirmation that we are on our patient's side. He was sent to the cancer center after an inpatient hospitalization, where his team had found a large stomach tumor, biopsy proven to be cancer, with metastases to many parts of the abdominal wall. It was unfortunately stage 4 at diagnosis. Now, he came with his wife and daughter to discuss treatment options. I ask him my usual questions and then step out of the room. His daughter approaches me and the attending in the hallway, closes the door to her father's exam room, and asks a humbling question. "Can you please not tell my dad his diagnosis?" She goes on to explain that the doctors had told him it was stage 4 cancer, but it was after a procedure where he was sedated and he didn't fully understand. The family, however, did. They knew how serious it was. And so to protect their dad, their thought was that it would be better for him if he got treatment without knowing exactly what he was being treated for. She didn't want him to lose hope. There's a template on how to handle this type of situation ethically. You ask the patient what his preferences are. If the patient says, "Yes, you can talk to my family about my medical care without telling me the details," then it's okay to do so. But if he says no, it doesn't matter what the family prefers, no matter how pure or kind their motivation. The patient's decision is the one that matters, and his autonomy trumps everything else. It gets tricky about how this plays out practically. What do you say the chemotherapy is running through the IV? What happens if and when he gets sicker and decisions need to be made about stopping treatment because he's dying? It's important to remember he can change his mind at any time. Saying "don't tell me" up front is in no way binding as the story evolves. There's an old adage that cancer can bring families together or tear them apart. I think about this as they argue in the room in front of me. At first, he disagrees with his daughter and says he wants to know, but then she and his wife convince him it would be better for him not to, and he acquiesces. So we don't tell him. I know it was technically the correct answer. It still doesn't make it easier to watch. Thanks for listening, and I hope you'll tune in next week for Clinical Correlation.
We hope you've enjoyed this best of episode of Blood and Cancer, the official podcast of MDedge Heme Onc. We'll be back with new content in episode 78. I'd like to take a moment now to thank the contributions of executive editor Mary Ellen Schneider. Mary Ellen is leaving us, and we wish her all the best in her future endeavors. It's truly been a pleasure. Blood and Cancer is produced by MDedge Hematology Oncology editor Jennifer Smith. All MDedge podcasts are produced by the editor-in-chief of MDedge and Medscape, Dr. Ivan Oransky, as well as executive editors Mary Ellen Schneider and Kathy Scarbeck. I am your audio engineer, audio editor, and the voice of MDedge Podcasts, Nick Andrews. You're listening to Blood and Cancer.